Hello, everyone, and welcome to another episode of Dr. Gilbert Hosts. Today, our broadcast is entitled Mild Cognitive Impairment and Parkinson's Disease. Now, this is a type of thinking difficulty that doesn't necessarily interfere with your ability to live independently or do the things you want to do. Those around you may or may not have noticed anything, but you notice something has changed in how you think. So we're going to be discussing cognition and Parkinson's in general. We're going to be discussing mild cognitive impairment specifically, how it's diagnosed, and what you can potentially do about it. And I wanted to take a moment to thank the sponsors of today's broadcast, which is Sage Therapeutics. I am very excited to introduce today's guest, who will help us navigate this very vital topic and will help answer all your questions, and that is Dr. Jasdeep Hundal. Dr. Hundal is a board-certified clinical neuropsychologist. He is director of medical and neuropsychology in the southern region of Hackensack Meridian Health in New Jersey. Previously, he was director of neuropsychology at the Rutgers Robert Wood Johnson Medical School in New Brunswick, New Jersey. Dr. Hundal completed his doctoral degree in clinical psychology from Roosevelt University in Chicago, Illinois, his neuropsychology internship at the Mount Sinai School of Medicine in New York City, and his residency and fellowship in the JFK Johnson Rehabilitation Institute Center for Head Injuries in New Jersey. Dr. Hundal's patient care philosophy emphasizes a comprehensive, integrative approach to diagnosis and management of brain-based disorders. He works to devise tailored treatment plans to maximize neurocognitive recovery and improve patient and caregiver quality of life. He's also involved in multiple research efforts in neurorehabilitation, and he teaches and lectures widely on all of these topics. Thank you, Dr. Hundal, for joining us today.
Thank you, Dr. Gilbert, and thank you for having me here. And hopefully we'll have a lively conversation after a short presentation where I will discuss cognitive changes in mild cognitive impairment and Parkinson's disease. And I assume, there we go. We can go to the next topic. So one of the things to keep in mind when we talk about cognitive changes is that over our lifespan, our thinking does change. There's a dramatic increase in cognitive abilities from when we were born to our mid-20s, at which point there's some divergence. Some skills continue to improve through our 70s, while other cognitive skills start to change or decline. Skills that continue to get better include things like general knowledge, some language abilities, while cognitive skills that begin to decline, even in our mid-20s, are things like cognitive control or processing speed. Now, this isn't a precipitous decline. They'll change slowly over time, but I want everybody to keep that in mind, that some skills continue to grow while others change, which is a normal part of the aging process. Next topic. So when we talk about cognitive changes in Parkinson's disease, really what we're looking at is changes in what we call executive functioning and visual spatial abilities. The slide's a little bit busy, so I'll break it down. When we say executive functioning, really what we're talking about are cognitive control functions. So planning, being able to retrieve information in real time, being able to focus and pay attention, those kind of things. And visual spatial abilities are spatial perception, being able to discriminate visual detail, that type of skill. Now, language and memory changes do occur in Parkinson's disease, mild cognitive impairment, or dementia, but they tend to happen later in the course. Earlier, you may have more retrieval issues, but they're not what we would consider a pure language disorder. Behavioral changes can also occur in Parkinson's disease, and some of these can change. Difficulties can occur early, while others will occur later in the disease progression. Depression, anxiety are some of the things that also are prominent and can co-occur early as well as later on. Now, let's go to the next topic. So when we talk about mild cognitive impairment, what we're getting into now is there are changes in our thinking skills beyond normal aging. So even though we do lose some cognitive control abilities starting in our mid to late 20s, when we talk about mild cognitive impairment, this is a change in normal aging compared to your peers. However, this change does not interfere with person's ability to function independently. And about 40% of patients with Parkinson's disease will start developing mild cognitive impairment within the first couple of years. And when we think about mild cognitive impairment, we normally break it down into subcategories or divisions. There's amnestic versus non-amnestic. There's single versus multiple domains. So what we're getting at there is if memory is involved, then we would consider it an amnestic mild cognitive impairment. And if memory plus, say, language skills or attention skills are involved, then we can call it a mild cognitive impairment amnestic with multiple domains of involvement. Majority of the folks with Parkinson's disease will tend to have a multiple domains categorization. Now, what are some of the risk factors associated with developing mild cognitive impairment? So not everybody with Parkinson's disease will develop an MCI, but the male gender, being older, lower education, and longer disease course do increase the risk of developing this issue. So as I was saying earlier, some of the symptoms could be retrieval issues. So this is where you struggle to come up with a name of something that you're looking at. Or, oh, what is the name of that actor that was in that movie? Or what did we do the other day? But it's not a memory issue per se, because with some prompting or cueing, that information should come back. You also may notice some changes in multitasking, as well as planning and organization. Next topic. Now, when cognitive issues also begin to interfere with your ability to function independently, we would call that Parkinson's disease dementia. And about 50% of MCI patients will convert to a Parkinson's disease dementia over 5 years. Next topic. So with that said, cognitive impairments can occur with Parkinson's disease. However, currently there are no disease-modifying medications that are available, but we are working on it. What we do now is we tend to develop interventions that focus on managing symptoms or mitigating them. But there is nothing out there right now that is going to slow down the disease progression or changes in cognition. One of the medication options that is available to help manage some of the cognitive symptoms associated with Parkinson's disease is a cholinesterase inhibitor like rivastigmine. Some of you may have heard of this. This is something that is actually used in Alzheimer's patients as well. Similarly with donepezil or Aricept, it's a medication commonly used in Alzheimer's disease, and it is proven to be effective to some degree with Parkinson's as well. One of the drawbacks is that in about 10% of patients in the control studies did show worsening of their tremor. Some of the other symptoms commonly associated with this class of medications is nausea or vomiting. Now, in addition to cholinesterase inhibitors, medications like memantine, which is an NMDA receptor antagonist, another medication used in Alzheimer's disease, has shown some mixed results. We can go to the next topic. And on this slide, you'll see a list of clinical trials looking at different medications to potentially help improve cognitive functioning in not only mild cognitive impairment, but also Parkinson's disease dementia, as well as Lewy body dementia, which is associated with Parkinson's disease. And there we go. So beyond medication, there are several other strategies that we can utilize to help mitigate or manage the cognitive changes that can occur with Parkinson's. I'll talk about each of these briefly. First is cognitive rehabilitation. We'll talk about exercise, diet, as well as invasive and non-invasive stimulation paradigms. And I'm hoping that we can elaborate more on these during our discussion after my talk. Next slide. So cognitive rehabilitation, when we think about cognitive rehabilitation, really what you should think about is it's an intervention designed to either maintain or improve a person's cognitive abilities to help maximize their quality of life and daily functioning. And cognitive rehabilitation comes in two flavors. There's restorative and compensatory. When you hear the term restorative cognitive rehabilitation, this is more often associated with neuroplasticity. So what we're hoping to achieve here is that through practice, through drilling, through repeated exposure, the brain relearns a lost skill. This is often useful in patients that have had a head injury or a traumatic brain injury, where they have to relearn a specific skill set, like being able to focus or pay attention. Compensatory interventions are utilizing either internal strategies or relying on external aids to help mitigate a skill that has been lost. This is what we would normally use in Parkinson's disease, is more compensatory strategies. Here you may learn to use your smartphone or smart devices to set alarms or reminders for, if you're cooking, you may set a 10-minute timer to turn off the stove. Or if you have an appointment, you would put it on our smart calendar and you would be alerted that you have a doctor's appointment coming up the next day. And these are therapies that are showing some promise, although that we're still in the early course of figuring out what is best for our Parkinson's population. There is some initial support that compensatory interventions are useful. Next slide. So in addition to cognitive rehabilitation, where we learn strategies, another wonderful activity that can improve brain functioning and overall cognition is exercise. Most of the research focuses on cardiovascular or aerobic exercise, and there we are seeing promise for creating a more resilient brain. Exercise is shown to improve global cognitive abilities, attention, what we call working memory, which is the ability to hold on to something, some information for short periods of time, as well as executive functioning. So the skills that we see deteriorating with not just normal aging, but also with Parkinson's disease. And some of the key elements to remember with exercise is intensity, duration, and frequency. And this is coming from a lot of different studies that find that these are the three main ingredients to help promote change. So when I say intensity, what I'm saying is you want to do an exercise that's challenging. It doesn't need to be, overly excessive, but you should break a little sweat. And it should be more than just a leisurely walk down the street. Duration is the other key ingredient, where we're really finding that you have to do 30 to 45 minutes or even up to 60 minutes to really benefit from that. From, say, using a stationary bicycle or being in the pool. To get any of the cardio benefits, you need to do more than 30 to 45 minutes. And frequency, which is you have to do it on a regular basis. It can't be something you do once or twice a week for about 10 minutes. You have to do it for 3 to 4 days out of the week. And as I said, it has to be challenging, and it has to be a long enough duration for your brain and your body to really maximize benefit. Next topic. And beyond cognitive rehabilitation, exercise is also diet. Here I mentioned the Mediterranean diet, but there's also the ketogenic diet. There's new evidence emerging from intermittent fasting as all ways to just promote better brain health. Now, with the Mediterranean diet and even the ketogenic diet, part of what we're seeing is a decreased amount of inflammation. Plus, with the Mediterranean diet, there's a lot of antioxidants in the type of foods that you eat. But if you look at this list, one of the things you'll notice is these are not processed foods. So they're minimally processed, if at all. And that's what the brain really craves and will benefit from, is more whole types of foods that are easy to cook, easy to eat, easy to digest. Next topic. So in addition to those interventions, there's also what we call invasive and non-invasive stimulation parameters and interventions that may help improve the way our brain works. Some folks have heard of transcranial magnetic stimulation, or TMS. This is something that's been used in depression and other psychiatric disorders. But we also find some benefit of TMS for improving things like working memory. The research here is still pretty early, so there's not a lot to pull from, and some studies are not finding any benefit. But when we pull the research together, there does seem to be some support for improving working memory, which is important for when we're having a conversation to remember what the individual had just told us so that we can respond in real time. Transcranial direct cortical stimulation. So this uses an electrical current versus magnets, which TMS uses. And this also seems to show some promise for improving cognition, and it's more along the lines of being able to stay attentive longer or vigilance. Let's see. And then with the invasive stimulation, we're talking about we are talking about deep brain stimulation, which is already something that we use for managing the physical symptoms. But we think targeting to the GPI, which is a common target for managing physical symptoms, with a secondary target of the NB, or the nucleus bacillus of Meinhardt, may actually give you some better cognitive outcomes. We're still in the early research stages on this one, so there isn't much data out there to look at. But so this is something to kind of stay tuned for. Next topic. And here's a list of some clinical trials that are looking at cognitive rehabilitation, diet, and those stimulation interventions to help promote better brain health. And here you'll see it's primarily in the MCI group. Go ahead, next topic. So with that, I'll close out by saying that, cognition is a normal part of aging, but with Parkinson's disease, there can be accelerated cognitive decline that does warrant further workup. Now, cognitive changes can result from brain-based issues associated with the disease itself, but you may also be dealing with side effects of other types of other interventions, whether it's medication side effects, whether you've had some sort of an illness, certain deficiencies, even depression, anxiety can change the way our brain works and reduce cognitive efficiency. Also, things like a lack of sleep, or folks that have obstructive sleep apnea, that can be a contributing factor in cognitive changes. But those are all manageable factors. So if you are worried about changes in your thinking, this is something to bring up with your treating provider. And if necessary, a more extensive workup can be done through a neuropsychological assessment, which is something that I do in my clinic, and I'm happy to talk about during our discussion. And I'll leave it there.
Fantastic. Thank you so much, Dr. Hundal, for that excellent introduction to our topic. The questions are rolling in. We have a number of questions already submitted. Lots of people have submitted their questions already. And I encourage you to continue submitting your questions now and throughout the discussion. And in order to participate in that live chat and submit your questions, you'll need to log into YouTube or Facebook. And remember, we may display your question along with the name and photo you're logged in with. So please be aware of that. So let's start. We have a whole bunch of really excellent questions already. Here's one from Jolie, which is that she finds that her carbidopa levodopa is good for her movement, but not good for her cognition. And if she needs to think too hard on a particular day, she'll take less medication that day. What do you have to say about that? Why is that?
Actually, that's somewhat surprising, because part of what we're actually hypothesizing is that medication not only improves motor function, motor control, motor abilities, but it actually may have some secondary effects on cognition. So, that's actually that's a good question. I'm not sure what that is. I think I would have to know more of the details around what's happening during the day. Are you having side effects from the medications like dyskinesias that may be tiring you out? But cognitive fatigue also is something to consider, where maybe if you want to do those cognitively engaging or stimulating or taxing activities earlier in the day or midday versus later in the day, where our brain naturally does wind down and get a little more tired.
Okay, thank you very much. John asked a question that I bet is on lots of people's minds. You mentioned normal aging a lot in your talk. How, if somebody comes to you for an assessment, how would you distinguish between normal aging and mild cognitive impairment?
That's a really good question. So part of the discipline of neuropsychology is that we are using instruments that are what we call that have normative data. So these are tests that have been administered to hundreds and hundreds of people, and we figure out what the average score should be. And then we have these variations from normality or from average. And we try to plug you into other folks or compare you to other folks that have as many similar demographic variables as possible. So age, gender, education, things like that. So we have a pretty good idea what someone should do or how someone should perform on this test, regardless of what age they are. And we just want to see how you do relative to your age-matched peers. And so on some skills, you may be better, some may be worse. And we also look for patterns. So there's enough data that we've already gathered, and we have these profiles that we should be able to fit you in pretty comfortably to say if this is normal aging versus something more concerning like mild cognitive impairment.
Okay, good. So it's not guesswork. There's a testing regimen that can put you in one of those categories. Thank you very much. We have a great question from Amaya. Again, I'm sure this is on lots of people's minds. So for family members who may suspect MCI going on in a family member, what advice would you suggest in how to bring that topic up to the person who perhaps is affected and their healthcare provider?
So, yeah, I think first I'd partner with the healthcare provider first, whether it's the primary care physician or the treating neurologist. Express your concerns to them, and then you guys can potentially work on a strategy together. Now, it also depends on the family member that has the cognitive changes, whether they're receptive to that conversation or they're, nothing's wrong. You're just, you're being too dramatic, that kind of thing. So, there's a lot of variables that you have to consider, but the biggest thing I'll say is you have to partner with your healthcare providers to make the best decisions. And that means even if you suspect something, this looks a little off, bring it up. There are screening instruments that neurologists and primary care physicians can utilize to guide them whether a more thorough workup is needed. But just creating that partnership is going to be very important.
Yeah, I wonder if you feel this as well. Sometimes when the person with Parkinson's or the family is sort of not sure how to talk with a person with Parkinson's about their cognition, sometimes I find that just bringing it up is a tension releaser because the person with the Parkinson's has noticed also, and sort of getting it into the open is something that they're sort of waiting for, and not making it sort of this secret that everyone's dancing around sometimes can be helpful to everyone. So
yeah, and I think you can bring it up in a non-judgmental kind of way as well. As, hey, I've been noticing this. I wonder if you're noticing the same thing.
Yeah.
And if you are, maybe let's talk to the neurologist about it, or let's talk to the primary care about it. Let's just try to get a little more information. So frame it along those lines.
Yeah, and what the positive things we can do to help about it. So we have a great question from Catherine, which is, does taking the antidepressant bupropion accelerate cognitive decline?
No, it does not. So that'll be my short answer on that one.
Okay, very good. So these medications do not cause neurodegeneration, so you can be comfortable with that. So we have a second Catherine who asked another really good question, which is, what the information you've presented about cognitive decline, does this also apply to young people with Parkinson's, somebody who may have had Parkinson's in their 30s or 40s, young onset PD? Do the same sort of rules apply for cognitive impairment as the disease progresses?
So the old rule of thumb was if you had an earlier age of onset for Parkinson's disease, you're just going to have a better cognitive course. But I'll say each person is different. Part of the risk factors for developing mild cognitive impairment is disease duration. So if somebody who's younger has been diagnosed, but they're only a couple of years in, maybe they're not going to notice it as much, or it will not be there, versus someone who's had this disease for 5 years, 10 years. Because once you start hitting those milestones, that does increase the likelihood of developing some cognitive changes, especially 10 years out. That's been a pretty solid marker for, like, say, Parkinson's disease dementia onset as well.
Okay. All right. We have a question from Corinne, which is, Do you have any suggestions about a medication dispenser for those who may have difficulty remembering to take their medications?
Oh, I think a pill box, something that you can set up for Monday, Tuesday, all the way through Sunday, is a wonderful idea. And I would also piggyback that with smart devices like we have an Alexa, or we have multiple Alexas in the house, and it reminds me to do all sorts of fun things like, take out the garbage on a certain day of the week. So having a pill box set for each day, as well as some sort of a reminder to take your medication, say at 9 a.m., at 12 p.m., at 4 p.m., is a really a good way to go. Now, is there a particular pill box that I think is better than the other? I don't think I have much of a comment on that, but just having an organizational strategy and using those type of organizational tools is going to be just a really good way to make sure someone is not missing their doses.
Yeah, I think it raises a really good point overall, that there's lots of devices out there that can help support cognition, that you don't have to go in on your own. If you're finding that you have issues with your cognition, look around and find these sort of ancillary techniques that can help you live as best as you possibly can. We have a question sorry.
I was going to say real quick, we all have a supercomputer in our pockets these days, which is your cell phone. Whether it's an iPhone with Siri or whether it's an Android, you can just tell it what to do and it will do it for you. So tell it to remind you to do things. Take advantage of it.
Yeah, excellent point. Excellent point. We have a great question from Ginny, which is a concern about cognition in people who've had deep brain stimulation. So are people who've had deep brain stimulation surgery less or more likely to have cognitive decline?
So deep brain stimulation is, so it depends on the individual. There are going to be risk factors for cognitive changes post-DBS. Those could be people that are more advanced, so they're not just in the mild cognitive impairment stage, that are in the dementia stage. There are other factors like psychiatric illness, age. So there's a lot that goes into that. But DBS in itself, there is some evidence to suggest that, say, a subthalamic nucleus, or STN, could potentially decrease verbal fluency and some other aspects of executive functioning. What we also find in that same group is that their quality of life doesn't change. So there could be some, say, hit to your cognition, but not a meaningful enough hit that it all of a sudden now puts you in a nursing home. There's a better cognitive side effect profile for a GPI target, which also seems to have some improvement with mood. But then part of the decision-making process there is, if you need to decrease your medication load, you're not going to do so much with the GPI versus the STN. So there's a lot that can go into it, but there is some risk of cognitive changes with DBS, but DBS in itself is not going to accelerate the dementia process.
And also important to note is that before a deep brain stimulation is done, everyone with a particular targets gets a full cognitive evaluation just to make sure that they're not having issues prior to the surgery. So there's a lot of thought that goes on before the surgery too. And that's, I'm sure, a huge referral to you. Yeah.
Yeah, exactly.
All right, Kathleen has a completely new topic that we definitely should discuss, which is, one of my major problems is lack of motivation, lost motivation. It's also called apathy. How does that fit into this picture of dementia, mild cognitive impairment? What do you say about that topic?
So actually, apathy could be one of the early warning signs that there is some cognitive decline that's happening. Now, apathy can be purely neurogenically driven, or it could be a component of depression. So that is something that needs to be flushed out in more detail. And so seeing a neuropsychologist would probably be a good way to go. But with apathy, if it's outside of the scope of depression, it is just sort of this lack of initiation, lack of motivation to do things. If it's in the context of a depression, then if we treat the depression, then the apathy and the motivation does improve as well. So getting a good workup that can help discriminate what's driving this sort of apathetic state is going to be important. Now, with depression, there are plenty of therapies, including medications, that can make those symptoms better. Even behavioral activation, which is sort of getting you into a routine, can help you kind of get out of that apathetic state. But again, if it's depression related, it's different versus if it's purely a neurogenic process.
Okay, thank you so much. We have a question from Elias. I started to have difficulty retrieving the right words when I speak. Do you have any specific exercises or any specific therapies you would suggest for somebody with that problem?
Sure, and that's a very common complaint that I get, whether someone is earlier in their diagnosis or even late. So word finding problems are sort of those issues in executive functioning and retrieval that I mentioned. Depends on how bad it is. If it's just, a mild form of it, I always encourage people, just talk around it. Try to find the word that's similar, but you can still convey your meaning and people understand what you're trying to get at. If it's something more significant than that, you may want to consider a speech and language therapy where they can really work with you on strategies to help you with word retrieval, circumlocation, other ways to, again, help you communicate effectively.
Okay, very good. So again, just emphasizing, you notice something, bring it up with your doctor. There are things that can be done. There are strategies, there are therapies, there are devices. This is not something you have to live with in silence. So thanks again for that. We have a question from Robin, and this question comes up again and again and again. It's a very hard question to answer, but I will pose it to you, which is, where does Lewy body dementia come into this whole conversation? And how do we understand that concept as well? What is it, and how do you explain it?
Yeah, Lewy body dementia is it's in the family of Parkinson's disease, but it's not necessarily going to have the same course. So again, a quick and dirty rule of thumb here is that if you have motor symptoms and cognitive symptoms within the first year of life, first year of diagnosis, not first year of life, within the first year, then maybe we are dealing with with the Lewy body dementia. And there's also more hallucinations, waxing and waning cognition. It doesn't respond to the same medications the way Parkinson's disease does. So management is going to be different. This isn't, you're almost, you're really going to bypass an MCI stage in a Lewy body and accelerate more towards a dementia stage. So, they're in the same family of Parkinson's plus syndromes, but they're not essentially the same thing. I don't know if that was very clear, but it is hard to tease those two in a simple way.
They're very. We as healthcare professionals don't understand it well, so it's very hard to explain. But the way I see it is that they're probably all different diseases along a spectrum, and knowing where one ends and the other begins is sometimes a little bit artificial, and so sometimes it's not, that isn't conveyed in all the different literature, so it can be really confusing for people. So I find it confusing too. So a great question from Dan, which is, what is a good source for cognitive practice? And what I think Dan means by that is, there a battery of cognitive practices you can do at home to improve your cognition? Where would you go for something like that?
Yeah, and I get asked that question a lot, and unfortunately, there really isn't anything that I can say, here, take this, take it home, and it'll exercise your brain in the way that we want to exercise it to improve functioning. My best advice is stay cognitively active, stay cognitively engaged. A real simple way to stay cognitively engaged is to have a stimulating conversation with your friends and family. Discuss current topics, have a debate. Use your brain or you lose your brain. And it sounds like cliche. Other things, people have said, do Sudoku or do jigsaw puzzles or do word search. I think those are fine as well, but they're not the end all. Those are just things to kind of keep your brain stimulated, but engagement, discourse, communication, that really exercises the brain in a lot of different ways. And it seems really simple, but it actually involves complex processes. So just keep your brain active, keep trying to be engaged. Some of the things that I've even suggested to my patients is plan a fake trip or plan a real trip. Go through all the processes of where you're going to go. How are you going to get there? What are the logistics involved when you're there? These are like mental exercises that really make you think. they use executive functioning, they use memory, they use attention, they use motivation. So just, try to stay engaged as much as possible. Pick up a hobby, build a shed. I like to make furniture sometimes. During COVID, I actually put a couple things together. But working through plans, cutting things to size, whatever is within your skill set or level or interest, just find those sort of activities that'll make you think. And I think that is the simple ingredient there. Is just you got to find something that makes you think and makes you work.
That is an amazing answer. I'm going to steal that one from you when I get that question, because I think that's so true. Another great question from the Owl, which is stuttering and stammering. Is that part of MCI? Bruce asked a similar question. He's had PD for 10 years, finds that he's stuttering with some words. What is that?
So that's probably more like a dysarthric sort of apraxia of speech kind of thing. And it can come on with worsening motor symptoms, tremors, things like that. Typically, when I think of cognitive issues related to Parkinson's disease, it's typically a problem of I can't find the word I'm looking for versus a trouble or difficulty articulating that word, or stuttering, or having a slurring of speech. I mean, I typically group those more along the motor symptom spectrum.
Got it. So, we've had a bunch of questions about that motor piece of speech. We've had a bunch of questions about the cognitive piece of speech, word retrieval. Joy just asked a question about word retrieval. So there are these two elements of speech. And you mentioned before, speech therapy can be really effective and can be effective for both of those issues. So yeah. Thanks for all the speech questions that are coming in. We have another question from David, which is along the same lines as what you just talked about. I just want to highlight what he's mentioning. There are specific online programs such as Luminosity and Neuron Nation that are available. Are these worth it to be doing some kind of these formal online programs?
I think it depends on who you ask, but I think the jury's still out on them. As it so happens, part of my research portfolio is I do computer-based cognitive interventions, virtual reality-based interventions. So, there are programs that are out there. I think the ones that are commercially marketed are probably not that level of complexity that you need. There's something to be said about repetitive exposure to items to help improve, say, attention, but they're not going to generalize well. Again, I go back to just, find other ways within your social environment, within your day-to-day life to just be more actively engaged. And I think that'll be just enough. That'll be sufficient.
Great. Thank you. We have a very good question from Tom W., which I think is really important to highlight, which is how can we distinguish between changes that we're discussing and mood changes that are caused by the disease? Because we all know that if your mood is affected, your cognition can be affected too. So
I always use this these sets of data points is that about 40% of patients with Parkinson's disease are likely to develop a depression. About 75% of the patients that have a depression are likely to have a comorbid anxiety. So mood-related issues is common. And it is hard to tease those out. Depression, anxiety can really reduce your capacity to live up to your cognitive potential day to day. One of the things I'll say is if you notice that you're having good days and bad days, and we can effectively rule out Lewy body dementia, then maybe we're dealing with depression or anxiety or something mood related. But if you've just kind of hit your ceiling and you can't go beyond that, and it doesn't matter what day of the week or month or year it is, then maybe it's something more cognitive. But here again, partnering with your care providers to do routine check-ins, to monitor cognition is what I'm going to recommend. That's the best way to tease those out. It's not something you're going to be able to do from home.
Okay, great. Thank you. Lots of people asking variation of this question, which is there's so many nutritional supplements and other compounds that are available for purchase online and in a nutritional store that say that they're good for cognition. What should people purchase, if anything? What are your thoughts on that?
Yeah, I'm still waiting for that one full randomized controlled trial study that says that these are actually beneficial. Look, again, I feel bad. I don't want to badmouth any industry or anything like that. All the claims these, I guess, manufacturers have are based on a small sample, small studies. I haven't seen it to where I would say if I had a family member who was on a fixed income to, hey, go out and buy this, I wouldn't recommend it. Again, I keep going back to the old trope of just, stay cognitively engaged, stay physically active. And guess what? Most of those supplements, those nutrients that you're going to need if you have a healthy diet, you're going to get them anyways. One of the things I'll probably add is like vitamin D. Those kind of things are fine. But if somebody's telling you take this because it's going to boost your brain functioning, look at the back of it. I bet you it just has a lot of caffeine. So have a cup of coffee.
Yeah. I often say to people that the whole is worth more than the sum of its parts. So a Mediterranean diet, eating the rainbow, you get everything in there, and teasing it apart and figuring out exactly what nutritional elements we're going to miss things. So just have the real food, and you'll get what you need.
Go to the source.
So we have a question from Janet, which is, what kind, again, it's back to the testing that you might do for somebody who comes to your office. What kind of testing would you do to determine what's exactly going on? What she asked is, are there any different types of Parkinson's happening? Perhaps, would you know if there's that Lewy body dementia element or MCI? How would you know where a person fits on the Parkinson's spectrum when you are evaluating them?
So everything that we're going to do is in the context of a full workup that involves neurology, that involves lab work, that involves imaging, that involves cognitive testing. So once we have all of these data points, we're able to give you a better sense of what is going on with you. So for example, dementia with Lewy bodies versus Parkinson's disease, there's going to be certain complaints or just a physical presentation. I'm saying that wrong. As in, there's going to be markers or there's going to be symptoms associated with those two different disorders that are going to help us discriminate. And then doing a cognitive battery is just an extra sort of level of information that will allow us to just have a clear sense of what may be going on. And I'm going to be very honest with you. Medicine, to a degree, is science, but there's also an art to it. So part of it is just how do you interpret all of that data? You may have some differences of opinions of two professionals looking at the same data points, but the more data you have, the better we can say, here's what we think is going on, and here's how we want to manage it. And I'll leave it at that.
Yeah, it's a complicated topic. So we have a question about driving. My wife does not think I should drive anymore, but I think she is overreacting. What should we do?
Yeah, that's a really good question. And that's something that comes up a lot for me as well. So driving, believe it or not, we take it for granted, but it's a very complex cognitive endeavor. It is not only requires complex thinking, but it also requires a lot of physical movements and reaction time. So part of what we see with Parkinson's disease is a decrease in response speed, motor speed, but also cognitive speed. So I would say if there is concern from the family that you should or you should not be driving, have this conversation with your Parkinson's care team. And there are programs that are out there that are what we call behind the wheel assessment programs. And they will put you in a car in a safe, controlled environment, and they will test you and they will see if you're someone who should or should not be driving. So if there's any concern, I would definitely pursue the medical route on that. Have those conversations with your care team, have a neuropsych workup to see if there's any issues with processing speed, reaction time, complex attention, working memory, problem solving, and also go do one of these behind the wheel assessments. And that should give everybody peace of mind. If you pass those assessments with flying colors, then your wife should feel okay that, all right, we're not going to put you at risk or put other people at risk.
Great. Thank you very much. Very, very important answer. We have actually reached the end of the time allotted for our Q&A, but I do want to get in one last question, which I think is very, very important to address, which has been asked, which is there is a new drug which seems to almost be getting approval for Alzheimer's disease. Really exciting. The first time, really. There was a bit of a little momentum last year, and now we have this potential new drug. Does this mean it can be used for Parkinson's as well? Is this the start of something for Parkinson's?
Short answer is no, because Alzheimer's is a different pathology. The medication that you're talking about, aducanumab or Aduhelm, which is I guess the brand name of it, is partially approved, and it treats amyloid, which is a pathology that's primarily linked to Alzheimer's disease. When we talk about Parkinson's disease, it's a different pathology. It's alpha-synuclein. Now, while this medication isn't going to translate to the Parkinson's population, there are trials, phase 1, phase 2 clinical trials that are looking at medications that may actually be able to deliver a similar sort of outcome, where we help manage the alpha-synuclein and how that impacts cognition. There's, I want to say, a couple dozen clinical trials looking at immunization, looking at clearance of this protein. So there's things that are on the horizon, but we're not there yet, I would say. So this drug, while it may wind up being useful for Alzheimer's disease, and again, the jury's out on that, and there's a lot of debate in that field, we don't have anything like that for Parkinson's just yet.
Okay, very good, but very exciting for us, as involved in the Parkinson's community, that there may be a step forward in this cognition field. We have reached the end of our session, of our broadcast, and there are many, many questions that have been unanswered. So I do want to apologize to everyone who has chimed in the chat. We can see your comments, so thank you very much for participating and for a lively discussion in the chat. So thank you so much. I want to thank Dr. Hundal, of course, for that presentation and for the answers to all the questions. I want to thank our sponsor of today's broadcast, Sage Therapeutics. I want to thank everybody who joined us and contributed to or just listened. Thank you so much. And if you know someone who missed today's program, or you'd like to watch it again, or you'd like to see the slides, this recording will be available almost immediately on our YouTube channel, so you can rewatch the whole thing and see the entire presentation again. Don't forget to subscribe to APDA's YouTube channel when you do that, and you will be alerted to future programming as well. So APDA can help you connect to other resources that you may need. So call us at 1-800-223-2732. Visit us on our website, apdaparkinson.org, and explore all that we have to offer. Before we go, I want to let you know about our next episode of Dr. Gilbert Hosts, and that's going to be on Thursday, November 17th at 4 p.m. Eastern Standard Time. And I'm going to be hosting a special guest then, Ted Thompson, who is Senior Vice President of Public Policy for the Michael J. Fox Foundation. Completely different topic. He is an expert in advocacy work for Parkinson's, and he coordinates the Unified Parkinson's Advocacy Council, or UPAC, which is a group consisting of national and local Parkinson's organizations, including APDA. And recently, this group spearheaded a remarkable new Parkinson's initiative called the National Plan to End Parkinson's Act. So we will be discussing that act. We'll be discussing other advocacy initiatives underway for people with Parkinson's and how you can get involved in those efforts. And of course, we'll be answering your questions. So please come and join us on November 17th. Be sure to stick around for a few final messages. Again, I want to thank you for joining us. We hope to see you on another APDA program. Have a fantastic day.
Hi, I'm Leslie Chambers, the President and CEO of the American Parkinson Disease Association. Each month, across the country, APDA is providing support groups, exercise classes, and educational programs like this one to support the Parkinson's disease community. You can find all of our upcoming virtual events on our website at apdaparkinson.org/events. If you enjoyed today's broadcast, I hope you will consider making a donation to help keep programs like this possible. Your gift can help APDA support people living with PD through local programs, reliable resources, and groundbreaking research designed to find treatments and ultimately the cure for Parkinson's disease. Please donate today at apdaparkinson.org/donate. And thank you so much for your support.